Hello everyone, this is Dr. Sushmita from TMH Medical Oncology Mumbai. I wish to thank Sir and Madam for giving an opportunity to speak today. I will be speaking on the session on triple negative breast cancer and the role of PARP inhibitors in the adjuvant setting. So I'm going to talk on the Olympia trial, that is a phase 3 multicenter randomized placebo-controlled trial of adjuvant olaparib after new adjuvant chemotherapy in patients with germline BRCA1 and 2 mutations and high-risk HER2-negative early breast cancer. So we are very familiar with the concept of synthetic lethality and the mechanism of cell death from synthetic lethality induced by PARP inhibition. So the study rationale is based upon the evidence that inhibition and trapping of PARP1 on the DNA results in synthetic lethality with loss of function of BRCA1 and 2 proteins and homologous recombination DNA repair. The role of olaparib as an adjuvant therapy in any germline BRCA mutated malignancy is untested, and thus the Olympia trial sought to examine this in high recurrence risk early breast cancer. So this is the trial's schema. Basically, the HER2 negative, be it hormone receptor positive or TNBC, stage 2 and 3 breast cancers or lack of PAT-CR to NACT in the adjuvant and the neoadjuvant group. Neoadjuvant group included TNBCs with non-PAT-CRs, hormone receptor positive with non-PAT-CR. They should have at least received 6 cycles of neoadjuvant chemotherapy. And then the adjuvant group included TNBCs with more than T2 or N1 tumors and hormone receptor positive with more than 4 lymph nodes were randomized 1:1 to either olaparib 300 milligram twice daily or to placebo. And the primary endpoint was invasive disease-free survival, with secondary endpoints being distant disease-free survival, overall survival, BRCA1 and 2 associated cancers. So this was the patient characteristics. They were very well balanced between the olaparib and the placebo group. Majority were BRCA1 mutated. As you can see, around 70% were BRCA1 mutated in both the olaparib and the placebo groups. Coming to the hormone receptor status, around 80% of them had triple negative breast cancers in the olaparib and the placebo group, and majority had received a combination of both anthracycline and taxanes. So the baseline characteristic and demographic profile were well matched. Coming to the Olympia distant disease-free survival, as we can see that the 3-year distant disease-free survival rate, the difference and benefit was around 7.1% with 95% confidence interval of 3 to 11.1%. Coming to the overall survival, the 3-year overall survival rate benefit was around 3.7%. Coming to the subgroup analysis of invasive disease-free survival, it is interesting to note that there was no statistical evidence of heterogeneity between any subgroup and the ITT-IDFS treatment effect, be it with the use of prior chemotherapy, prior platinum, hormone receptor status, or the BRCA1 and 2 mutations. Coming to the point of interest, that is the adverse events. As we can see, the grade 4 adverse events were quite a few, only 1.9% in olaparib group versus 0.4% in placebo, and adverse events leading to permanent discontinuation of treatment was around 9.9% in olaparib group versus 4.2% in the placebo group. The adverse event of special interest, that is the MDS, was around 0.2% in the olaparib versus 0.3% in the placebo group. So to conclude, the patients with high risk HER2 negative early breast cancer with germline BRCA mutation, as we know that they have significant risk of an increased chance of getting an invasive disease-free survival, distant disease-free survival despite standard therapies. Adjuvant olaparib for 1 year significantly improves the invasive and the distant disease-free survival. The toxicities were limited and manageable, and the germline BRCA1 and 2 were now found to be important biomarker to be sequenced in early breast cancer. Coming to the next topic, that is the quality of life results from the Olympia trial, that is by the Patricia Gans et al. The rationale behind studying the PROs was, will the addition of olaparib after standard neoadjuvant therapy cause additional toxicities, and whether this will lead to an exacerbation of pre-existing fatigue and delay in improving or recovering from the toxicities. So the primary objective was to determine the effect of olaparib on patient-reported fatigue at 6 and 12 months after randomization, that is the FACIT or the fatigue scores. Secondary objectives were to determine the effect of olaparib over time on the PROs, including 12 to 24 months post-treatment. That included fatigue, GI symptoms, nausea, vomiting, diarrhea, functional QOL subscales with particular interest in the physical and emotional subscales, and also the global health status. So as we can see, the mean FACIT score in healthy females is 43, and the baseline score is worse in the Olympia patients. So coming to the FACIT fatigue score change from baseline at 6 to 12 months, patients treated with olaparib slightly experienced more fatigue than patients treated with placebo, but the difference was statistically significant but not clinically meaningful. Coming to the fatigue scores over 24 months, the fatigue severity difference between olaparib and placebo did not meet pre-specified clinically meaningful difference at 6 and 12 months, and there was no difference at 18 and 24 months. Coming to the nausea and vomiting over 24 months, there was no difference at 18 and 24 months with olaparib and placebo groups returning to the pre-treatment levels. The URTC QLQ C30 diarrhea scores over 24 months also showed that the diarrhea symptoms, there was no difference between olaparib and placebo over time. Coming to the emotional functioning, there was no clinically meaningful differences between olaparib and placebo for emotional functioning subscale over time for either chemotherapy group. And also there was no clinically meaningful differences between olaparib and placebo for the global health status over time for either chemotherapy group. So to summarize, through all the presentation, we learned that olaparib was well tolerated as additional adjuvant therapy. There was no clinically meaningful increase in fatigue with recovery after 1 year. Nausea and vomiting were slightly worse, but they also recovered after the end of treatment. QOL's scores and global health slowly improved during 24 months after end of new adjuvant treatment, and 1 year of olaparib does not meaningfully affect recovery after standard of care new adjuvant therapy. Thank you.